So now we move into the intraoral adjustment. We're typically now looking at occlusal contacts, not interproximal contacts. The interproximal contacts are managed out of the mouth. I try and manage as much as the occlusal contacts out of the mouth as well. When you have a zirconia restoration, because of its strength, I can more adequately check the occlusion before cementation. When you get into materials like a lucite, Empress type restoration, or even Emax lithium disilicate, if you try and adjust all of the occlusion before cementation, you increase the risk of having that fracture. Now with monolithic zirconia, it's significantly stronger, so I can have the patient occlude and grind harder without traumatizing the ceramic. So I do as much as I can out of the mouth. But then we move into the mouth, and we're going to use a friction grip slow speed attachment and a latch slow speed attachment on an electric handpiece. The key again for me is the electric handpiece. It maintains torque at slow speed, and that gives us the efficiency. If you have air-driven slow speed handpieces, sometimes at slow speeds they begin to slow down or even stall. So the electric handpieces are very valuable. Use a fine or extra fine diamond for adjusting if you need to, and honestly, adjusting occlusal contacts, I find I tend to use more fine diamonds than just going immediately to a rubber wheel. Of course, it's determined by how much adjusting I have to do. And then finish off the surface by going through the sequence of medium and fine rubber wheels. So the advantage of an electric handpiece, I can control the setting on the box. This Brasseler 1-to-1 ratio handpiece will run at 40,000 RPMs, but I never want to go more than 20,000 RPMs, so I dial the box down to achieve a maximum only of 20,000 RPMs. I'm normally going to operate the diamond probably 15,000, but I don't want to go beyond 20. That way I'll minimize the trauma in the ceramic. So we're going to first check the occlusal contact with AccuFilm. Once again, using the Vaseline, it allows us to identify the occlusal contacts more easily than without the Vaseline. After I do that, I use one of two diamond burrs. They're both so-called football shape. One is a little bit flatter than the other. You'll see that in just a moment. The maximum speed I'll operate the handpiece is 20,000 RPMs, and use an air-water spray to keep the handpiece, burr, and ceramic cool. So I use Iolite Diamonds, one in particular, and that's the center one here, the football shape, as well as the cylinder, the 856016 fine grit diamond. That's a Iolite diamond. The football in the center here tends to have a little bit flatter surface, so it allows me to get into the anatomy better on posterior teeth. I like the traditional football shape for the palatal, the upper, because of the concavity. The round shape is actually more easily manipulated to adjust my contacts. So those are the three diamond burrs I might use. The long cylinder or taper diamond is more specifically used for proximal contacts or reshaping if necessary for aesthetic reasons. The other two are the ones I use for adjusting occlusion. So here, the occlusal surface of the posterior tooth, I'm showing it out of the mouth simply for the visualization using a microscope and showing all the different angles of light reflection. I can move the restoration around to show you the various surfaces. The handpiece is being kept in one spot. If I work clinically, obviously the handpiece is moving into the different angles to do the adjusting. The key with a fine diamond burr when you're adjusting the occlusion, try to avoid developing concavities. You don't want the opposing tooth to fall into a concavity and get locked into a little bit of we'll call it a bowl facet. So you want to maintain convex surfaces if possible. So the research will show that a fine grit cuts more efficiently than a medium grit when we're dealing with adjusting zirconia.